Okay, so current management of the recurrent pregnancy loss. Today we will see what are the causes, what are the epidemiology, what are the treatment available, latest available treatment. So we will discuss it together. So first of all, introduction. Introduction is the management of the recurrent pregnancy loss is a challenging clinical scenario with associated psychological trauma. The problem is the recurrent pregnancy loss for RCOG. They have been updating their guideline, and soon, maybe in coming months or coming weeks, the latest guideline will come. So the last guideline was in 2011, and then there is a Asher guidelines 2017, which is the European Society of Human Reproduction. We have to cover some of the topic from this website also. They have presented their guideline in 2017, and definitely American board ASRM, they have their guideline on 2012. So there is a significant difference, and in this article, in this talk article, actually they compare all the differences, and I hope that when this RCOG new guideline will come before the exam, you will already have already this talk article will help you what is the latest randomized controlled trial. The result has already came for an unexplained recurrent miscarriages. So you already have the knowledge, and then they will just make some recommendations. So definition of recurrent pregnancy loss, actually there is three definition. So in the UK, basically traditionally they said this is a loss of 3 or more consecutive pregnancy before 24 weeks of gestation. And the number they are quoting 1 to 3%. So, hello, any problem? Is there any problem? So it affects the 1 to 3% of all people trying to conceive. Okay. So this is the 1 to 3%. It is from the Green Top guideline. This is the incidence. A miscarriage is the spontaneous demise of a pregnancy in utero before the fetus reaches the viability. In the UK, this definition applies up to 23 weeks and 6 days of the gestation. And but some countries they use 20 weeks. RCOG define recurrent pregnancy loss. Now, first of all, they define the definition of miscarriage, which is less than 24 weeks, and in some other country it is 20 weeks. But now, and also the recurrent pregnancy loss is the loss of 3 or more consecutive pregnancy. For RCOG, it should be consecutive. But the updated RCOG draft guideline, they states the miscarriages do not necessarily have to be consecutive to be defined as recurrent miscarriage. So this thing we already now know the draft guideline. They said no need if the patient have two miscarriage and then after that live pregnancy and then again one miscarriage, it is again recurrent pregnancy loss. So this is for all three guidelines. Now it's the same. Now, American board, they define recurrent pregnancy loss 2 or more failed clinical pregnancy. It is a clinical pregnancy which is confirmed by histopathology or it is confirmed by ultrasound. So they considered it clinical pregnancy only. The Asher definition is it's a loss of 2 or more pregnancy, but they also didn't specify that it should be consecutive, but it acknowledged that this definition may be extending or need constricting. This definition need to be modified. And American guideline, they involve only the clinical pregnancy, which require ultrasound and histological confirmation of the pregnancy. RCOG consider pregnancy from conception, so biochemical pregnancy, RCOG also, they are including. So this is very important because when you are talking about the biochemical pregnancies of 3, then that's mean you are talking about 22%, which is biochemical pregnancy. But if you're talking about the clinical pregnancy, recurrent pregnancy loss rate, it is 0.3%. So there is a much difference. So by this percentages, we know that how important is the definition. So they make one table, very nice table. In the RCOG, they make this pregnancy, all pregnancy losses not further defined. They just mention all pregnancy losses from the conception The day the pregnancy test become positive by ultrasound histopathological diagnosis, all pregnancy losses. American board, they said clinical pregnancy by ultrasound or histological examination only. Asher, they said this beta HCG and ectopic molar pregnancy, they didn't include the definition. So they excluded the ectopic pregnancy and molar pregnancy. And on these pregnancy, they didn't mention in the definition, and the definition is still needs some modification. So miscarriage, it is up to 24 weeks in UK, but American, they mentioned that majority is lost. They didn't mention any cutoff. They just mentioned that majority is lost prior to 10 weeks. That's it. And Asher, they also mentioned 24 weeks. Recurrence in this one, RCOG, they said they need 3 recurrent, but now updated graph guideline, they said no need recurrent pregnancy, consecutive pregnancy loss. And AS American board, they said if there is a 2 or more, then it is a recurrent pregnancy loss. And Asher also 2. Okay, so consecutive or non-consecutive Asher, they don't know it is they just mention recurrent pregnancy loss, either consecutive or non-consecutive. Okay, so I think this is clear. So epidemiology, while 1 in 8 recognized pregnancy and in the pregnancy loss, the prevalence of recurrent pregnancy loss is 1 to 3%. So mostly it is lost by embryonic aneuploidy, which is associated with chromosomal segregation error in the oocytes. So they talk about some this chromosomal detail that because there is an error and because it's spindle activity, there is a reduction and there is a non-disjunction during meiosis and telomere. They talk about this thing, and then majority of this incidence increases, these error, chromosomal error increases if there is a prolonged arrest of human oocytes, because there is a arrest of this if you will go back to the physiology, you will know that there is some the oocytes, they are arrest at some phase of meiotic stages. So if they are arresting at this stage for long time, for example maternal age, so it will lead to these chromosomal errors, and this is an independent risk factor for recurrent pregnancy loss. And they said it depends on the age of women. For example, if 20 to 24 year woman, it is 0.1%. And if it is 40 to 44 years, then it is 13%. It increased 100 folds. So they said the woman over 40 years of age, the most likely causative risk factor is untreatable. So you have to consult the patient. If the a patient, if in the exam there is a patient, she is 40 years and she came with recurrent pregnancy loss, then you have to select the option that most probably, if she has previous live pregnancy, now she has most probably the age is the main risk factor. So there is a chart here. This is RCOG guideline, from RCOG guideline. You can see here this 20 to 24, it is 11% miscarriage risk, and if 40 to 44, it is 51%, is more. And also, if there is extreme of age less than 19, also it is more risk, 13%. So you this miscarriage risk, usually in the exam they are asking more than 45 years, the risk is 93%, and 40 to 44, it is 51%. Even 35 to 39, the risk of miscarriage is 25%. It is an age-related risk of miscarriage. It is not the risk of recurrent miscarriage. It is risk of miscarriage. So you already did one recall here. So I am telling, don't run after the recall, because in the recall you will find this question and then you will go back to the guideline. So usually the recalls are coming from the guideline, and usually this is the recall. This area, this is the recall. Okay, so etiology, there is a chromosomal abnormalities of the fetus. This is the most common cause. So again, the talk article, whatever the most common, you have to underline this one. So it is the most common cause of pregnancy loss, and at 70% it because of chromosomal abnormality, and only 20% of those occurring between 13 to 20 weeks of gestation. Majority, they are occurring in the first trimester. the 70% of early pregnancy losses, and 20% if there is a, for example, they are talking from 100% pregnancy loss, then the 70% due to chromosomal abnormalities. If it is between 13 to 20% pregnancy loss, then out of that gestation, 20% will be the chromosomal abnormalities, and the rest 80% will be other causes. So don't confuse yourself. This is 70% out of 100% in the early trimester, and this 20% is between 13 to 20 weeks. So in the second trimester losses, you think more about the thrombophilias or cervical incompetence or infection or other causes. So the most common chromosomal abnormality, out of this chromosomal abnormalities, the numerical chromosomal abnormalities, aneuploidies, it is the commonest. So first of all, the most common chromosomal, this is the most common cause, and out of this most common, numerical chromosomal abnormalities are commonest. It includes trisomies 52%, okay, polyploidy 21%, and monosomies are 13%. So these are important, because usually they love to ask about commonest and important percentages. So trisomy is believed to result of non-disjunction during the maternal meiosis one. Uh, so it is risk is high if the patient, if the woman is older than 35 years of age. So which support the association of aneuploidy and increasing maternal age. So they find the meta-analysis, and they said uh, no difference in the percentage of chromosomal abnormality found in pregnancy loss tissue between those with sporadic pregnancy and those with recurrent pregnancy loss. So definitely, if they will find the 100 samples, either it is a sporadic or either it is a recurrent pregnancy loss product, there is no difference. The chromosomal abnormalities will remain the 70% of the cases, and if it is trisomy, majority will have trisomy. Then parental chromosomal abnormalities, it is 2 to 6% of patient they have the parental carriership. They most commonly they have balanced reciprocal or Robertsonian translocations, either balanced reciprocal or Robertsonian translocation. So they have a high chance of healthy live birth in a future pregnancy. So this one, reciprocal or Robertsonian translocation, this is a very common exam question. So when you do genetics, please see the examples of balanced reciprocal or Robertsonian translocation, or see today, because sometimes questions are coming from this type of genetic problems. Actually, it came to me in the exam also. Congenital uterine abnormalities. Congenital uterine abnormalities are frequently associated with recurrent pregnancy loss. Prevalence is 13% with a history of miscarriage compared with 5.5%. If there is an unselected population, it is 5.5%. But if you will see the woman with a history of miscarriage, it is 13.3%. So it's more, almost 8% more. So in high risk population, uterine septa, this is again very important question, very exam question. The uterine septa are the commonest. They're asking, this is also recall question, what is the most common congenital uterine anomaly? The uterine septa are the commonest. And most patient with this congenital uterine anomaly, they have normal reproductive outcome. Then there is acquired uterine abnormalities like fibroid, polyps, uterine adhesions, but there is a lack of direct association. Okay, so chronic endometritis, it is also associated with recurrent pregnancy loss, and they did one observational study, and in this study they actually used the immunohistochemistry, and they identify the CD138 plus cells, and it was helpful in diagnosis of chronic endometritis, and for predicting further reproductive outcome. I remember there is a RCOG station, it was RCOG franchise station, and they give one picture of endometrium in which it was pointed out, or it was labeled that there was plasma cells, and they were asking the diagnosis. Actually, they were not asking the diagnosis, they asked in the question, what is the further management? So sometime now they are giving the pictures also, the graphs also. So maybe they will give you the chronic endometritis picture, and in which there is a plasma cells will be shown. Plasma cells are the B cell, this cell mediated immunity, the B cell memory cell, not the memory cell, the B cells, they are making the plasma cell, and then later on, I think they are making antibodies. So the plasma cells is related to T cell cell mediated immunity, and it is related to chronic endometritis. So think about that picture. Maybe it can come in the exam, and then they will ask you about the question that this CD138 cells, they are using this immunohistochemistry method, and then they predict the reproductive outcome. There are one trial is going on, it is called the SERM trial. And in this trial, if the women have 2 or more consecutive pregnancy loss, uh, and if they will positive for chronic endometritis, they will give them 100 milligram doxycycline twice daily for, or a placebo for 14 days, and see the pregnancy outcome will be compared. So this major trial is going on, and they will see. The cervical insufficiency, it is common in the second trimester, and there is no more recommendation for outside of pregnancy. Before, if you will see, there is a guidelines, maybe before pregnancy, do hysterosalpingography or cervical dilatation or some, but or digital assessment of the cervix. Now they are saying it is no more recommended, these investigation. And hydrosulfings 2019 systemic review, they said that if you will give treatment, it can actually decrease the risk of this hydrosulfings if you treat the PID. But the problem is this study was done in the IVF patients, so you cannot apply to the general population who conceive naturally. So this is the problem. So hereditary thrombophilias, for example, factor 5 latent gene mutation, prothrombin gene mutation, and deficiency in antithrombin and protein C and protein S deficiency. These are the hereditary thrombophilias. So they, although they are associated with adverse pregnancy outcome, but the association is very weak. In 2019, they said the treatment of hereditary thrombophilias improve the pregnancy outcome in recurrent pregnancy loss. There is no evidence. So usually when in the pregnant woman, if she will give you the history that she's a carrier of protein C or protein S, not symptomatic, this one, only they are saying if they are carriers, if they are asymptomatic carriers of these one, the treatment of asymptomatic hereditary thrombophilias do not improve the pregnancy outcome. If they are symptomatic, mean they due to thrombophilias they have risk of thromboembolism, then definitely you will give them aspirin or Clexane. But if they are asymptomatic, only because they have hereditary thrombophilias, there is no evidence that you will give them treatment and it will improve the pregnancy outcome. So acquired thrombophilias, these are antiphospholipid syndrome. It is the commonest acquired thrombophilia. So commonest acquired thrombophilia is APLS. And the prevalence in the recurrent pregnancy loss patient is 5 to 20% as compared to low risk obstetric history. If the patient is low risk, the risk of having this APS is 2%. But if the patient have recurrent pregnancy loss, there is a chance that 5 to 20% she will have this uh, acquired thrombophilia. So thyroid disorder, they said hypothyroidism increase the risk of recurrent pregnancy loss, but hyperthyroidism and recurrent pregnancy loss, there is a no link. Also, there is a less clear picture for subclinical hypothyroidism, and subclinical hypothyroidism means there is an increased TSH and normal free thyroxine. So only the elevated TSH and thyroid autoimmunity, the thyroid antibodies are also present. So there is a lack of data, and their newer guidelines are coming, and now they are setting that if upper limit is 4 rather than before 2.5, because in if you will read the previous old TOG article, the thyroid and the thyroid problem in the pregnancy and sufferability related to subclinical hypothyroidism, they said the target of the TSH was 2.5, and they discuss in that talk article that to keep the thyroid level, TSH level 2.5 is a target, and sometimes they are giving the patient low dose thyroxine to keep TSH level 2.5. Now the latest one is now telling the target TSH is now 4. So from this example, now you understand that you have to study the latest one, the latest talks, the latest things, or the latest book, because in the old books the references now change. So you don't know, because you are reading the first time. If you are reading the first time and you didn't read the old one, and you will open the book and you will become confused yourself. So better read the latest things first, and then go back to your books and use the book as part of your practice. And the answers you should already know, because answers are old now. Okay. So a systemic review and meta-analysis in 2020, they said there is no association. Now 2020 they make this conclusion. And before last talk article, because that time it was 2016 or 15, I think, this article, there was no systemic review or meta-analysis. But now they say there is no association. Subclinical hypothyroidism, recurrent pregnancy loss, although there is some association with thyroid autoantibodies, but you are not giving them treatment. So even if they have thyroid autoantibodies, you are not going to give them immunotherapy. So diabetic patients, diabetes is also associated with pregnancy loss. High hemoglobin A1C in the first trimester, definitely it is increases the pregnancy loss and fetal milk formation. But if well-controlled diabetes, is not a risk for recurrent pregnancy loss. Prolactin disorders, they said no clear evidence, either prolactin deficiency or hyperprolactinemia. So if the patient have hyperprolactinemia, you give them bromocriptine, it increases the live birth rate. If polycystic ovaries, there is association with the polycystic ovary and the loss rate, and because of hyperinsulinemia, hyperandrogenemia, but there is no evidence to suggest PCOS predisposed to recurrent pregnancy loss. Before, in the old guideline, RCOG guideline, they said there is a association. They write, I think, what my memory is working, because I didn't open the RCOG guideline. I think it was very high, something around 40%, very high they are saying. But now they are saying PCOS there is no evidence. Okay, so it's changed now. So I suggest you don't read the old RCOG guideline, because new guideline will come. And until then, you can read this TOG article, because all the reviews are from 2020, the latest one. So ovarian reserve 2020 systemic review meta-analysis, they said there is an association between damaged ovarian reserve and recurrent pregnancy loss. But definitely you need more data, because either you will use AMH or enteral follicular count, or not, you need more evaluations and more studies. So luteal insufficiency, no clear definition, and there are many pathologies, because sometimes with prolactin disorders, also luteal insufficiency can occur, and there is no evidence-based investigation so that you diagnose this condition. So there is until now no direct association. So male factors, also there is a growing body evidence in 2020 systemic review that increased sperm DNA fragmentation index, DFI. It was associated with recurrent pregnancy loss, and the treatment and prognosis still lacking. But they just diagnose it until now, but no treatment and no prognosis. Unexplained recurrent pregnancy loss, some women, some patient, they will never identify reason for their pregnancy loss. So, they have several treatments in the guideline. Last guideline I remember, they have plenty of treatment for these patients, the immunotherapy or leukotrienes or partner related WBC injections. I don't know too much for this group. So retrospective cohort review in 2018, they specially review the adjuvant treatment, and they concluded that 2/3 of those with recurrent pregnancy loss will have a live birth rate. So this is very important in the pregnancy counseling, that if the patient have unexplained recurrent pregnancy loss, you can counsel them that 2/3 of the chance, there is a chance, I think 2/3 is almost more than 65%. So 66%, that they will have a live birth. An empirical adjuvant treatment does not appear to offer any additional benefits. So if you are giving, you will see that in the GPs and there is private practice, they are giving the patients the steroids, and later they will end up in GDM and the miscarriage and the prom and the preterm labor because of steroids. So you need to consult them, and they are insisting me also in the OPDs also that start steroids for these patients, recurrent pregnancy loss. So until now, unless we have the definitive this one evidence, we should not start any type of this treatment, and we have to consult them. Still, there is a 66% chance that they will have a live birth. So this is the summary now. Effect of pregnancy loss: alcohol, no evidence, but better to avoid. Okay, caffeine, no evidence. It's sensible to avoid. Exercise, high intensity occupation activity. You have to avoid this one, and you have to do sensible exercise. Family history of pregnancy loss. For example, there is a they might have family history who miscarry, and still further research is needed. Maternal age, definitely we know maternal age is related, and aneuploidy pregnancy loss number specifically increases. Occupational environmental exposure, no evidence, and avoid exposure to the possible hazardous substance during pregnancy, because occupational environmental may be sporadic miscarriage maybe, but for recurrent pregnancy loss, environmental will cannot be, no evidence. Okay, so these are the alcohol, caffeine, exercises not related, only family history maybe and maternal age maybe. No, maternal age definitely. Okay, occupation, paternal age risk increases with advanced paternal age, especially after 40 years. This is same in the RCOG guideline. They also write 40 years. There is a risk, and less pronounced effect than maternal age. No, maternal age is more important. So previous pregnancy loss, definitely there is a, if there is an increase, if there is a previous pregnancy loss, it will increase, and percentage of pregnancy losses with euploidy increases. For example, if you will do karyotyping of the product of conception, and if it come out to be aneuploidy, then this is a good news. Why? Because you can tell the patient that now in the next pregnancy you have a more chance that you will have the normal pregnancy. But if the product of conception came euploid, then the chances of having next pregnancy to be miscarry is more. So this is something you need to be keep in your mind, because maybe in the exam they will manipulate this information, that maybe you will think that if normal euploidy, you can, what you will consult the patient, you will consult the patient that the percentage of pregnancy loss with euploidy increases, next pregnancy more chance that they will have aneuploidic pregnancy or miscarry. Smoking, no evidence, but definitely poor outcome. Stress, no evidence, but recurrent pregnancy loss can cause significant stress. And weight and BMI, risk increases with BMI above 25. Evidence, there is a evidence from assisted reproductive treatment. They see this evidence, and definitely associated with obstetric complications. Okay, so who should be referred for review? So they said in the UK, but now the dilemma is after 3 or after 2, when you will refer to the specialist clinic, because they have specialist clinic recurrent. After, if you will send them after 3, definitely you will lose the chance, if or you will delay their chances. Maybe the third pregnancy, it was due to treatable cause, and you did not refer them, and because you follow the definition, and but if you will follow the definition, you will end up in sending lots of referrals and lots of burden on the NHS services. So they said that still you can consider after, because ASHA guideline has been published in 2017, you can consider after 2 or more, but need further research is recognized. So a systemic review, they said uh, that while the studies support the notion that investigation may be carried out after only 2 pregnancy loss, the overall low prevalence of abnormal test result, as well as the limited amount of evidence-based treatment available, warrant caution in recommending this routinely. Because if you will diagnose, then what? Then what? Your treatment options is not so much. So they are actually discouraging, and they are insisting, but in the special cases or case to case, after 2, still you can. But RCOG, until you will wait for RCOG next guideline, according to Asher, you have to do investigate after 2 or more. Okay, so the management of people is multifactorial. First of all, lifestyle, psychological support, and specific treatment of any identified cause. This is the general management. So first of all, they have the couple should both together should be seen. This is the first thing, and the first consultation, medical, obstetrical, family history, also the lifestyle for the male and the female, also smoking, excessive alcohol consumption, excessive exercise, being overweight, underweight. These are all very important. Okay, and also it's important because they are usually these patients, they are very depressed, angry, guilty, or sad. So even they said, even in the staff outside who are calling them in the clinics, the nurse or the secretary, they should also take care of those patients, and they should also be very gentle with them because they are high risk for having psychological problems. So you have to treat their psychosocial needs also. So investigation, what investigation you will do? First of all, chromosomal analysis. Okay. So chromosomal analysis you will do. They said because now difference in recommendation, because now they are not doing karyotyping. If you have already read the NIPT guideline, they will tell you now instead of doing fish karyotyping, they are doing now more advanced technique, which is ACGH. This is more advanced technique. So many because with karyotyping, FSH, sorry, this one fish technique, maybe the result was coming, I forget, but I think after 48 hours, or the culture will take 2 weeks. But with this new technique, the result will come, and then accordingly the recommendation has been changed. With referral criteria to an recurrent pregnancy loss services, 3 consecutive first trimester losses, product of conception analysis is not carried out until the third pregnancy loss. Until now she told like that. In this article they told because of RCOG, they said the third one, the third product of conception should be sent for karyotype analysis. Genetic testing of product of conception may be of psychological benefits because it will help them to prove with the reason. So ultrasound, you will do 2D because it's a first line investigation for uterine anomaly. If they will ask you what is the first line investigation for uterine anomalies, please search for 2D pelvic TVS. Don't just do abdominal scan or just search for this specific line. 2D pelvic TVS ultrasound is the first line investigation for uterine abnormalities. So after that, hysterosalpingography also is good for screening low risk women, and 3D pelvic ultrasound is recommended to diagnose and classify this congenital uterine abnormalities accurately. So please, if they will ask you what is the first line investigation, this is 2D pelvic TVS. And what is the screening test? Then after that screening test, you can do hysterosalpingography. And also they said if you want to classify and you want to diagnose, then after that 3D. So definitely if 2D, you do first 2D and then you suspect something because it's like as a screening. So if you will do this one, because or sometime you are doing hysterosalpingography first line, you are having a low risk patient, she came to you for infertility investigation and you are doing hysterosalpingography, then you can find the shape of the uterus. So both are in different scenario, they are good options. But 3D pelvic ultrasound, they can classify better this abnormalities. MRI, laparoscopy, and hysteroscopy, they can all be considered on individual basis for complex type or acquired uterine abnormalities. So MRI, laparoscopy, and hysteroscopy will depends on situation, what is available, and you can use any of these one. Either you can do a high risk patient, you can do laparoscopy, either you can do hysteroscopy, either you do MRI, it's accordingly. But complex cases need this invasive diagnostic modalities. So thrombophilia screening. So for hereditary thrombophilias, only if you have additional risk factor. For example, if the patient has strong personal history of thrombosis, or she has family history of thrombosis or thrombophilia, then, or if you want to do research. Otherwise, routinely you are not asking for screening of these five thrombophilias. Okay, this thrombin deficiency, protein CS deficiency, or this one prothrombin gene mutation, you are not doing a routine. And diagnosis of APS require clinical manifestation. We know all the criteria. It is the clinical criteria. If there is a clinical vascular thrombosis, or if there is a pregnancy morbidity, we all know those criteria. Okay, and the presence of at least one antiphospholipid antibodies on two more occasions 12 weeks apart. So they need two things: clinical manifestations, or which is vascular or pregnancy morbidity in the history, and then you find one antiphospholipid antibodies 2 weeks apart. So what we are screening anticoagulants, anticardiolipin antibodies, and we are screening IgG and IgM, and then beta 2 glycoprotein 1 antibodies, which is again antibodies, this one antibodies to GP1, IgG, and IgM. So whenever you are asking for these antibodies, you should write IgM and IgG, both. In both cases, you need to write both. Okay, so endocrinological and metabolic investigation. So TSH you will do for screening of hypothyroidism, and if TSH is greater than 4, then you will do thyroxine. You need routinely, you will just order TSH, and if TSH abnormal, then you will do T3 and T4. The glycated hemoglobin test investigation for diabetes, especially if there is a risk factor or if there is any clinical evidence suggestive of diabetes. Also, if there is a clinical sign of hyperprolactinemia like oligo or amenorrhea, then you will do prolactin test. Routinely, you will not do all the tests in all the patient. You will do specifically if the patient is giving history or if patient is high risk. Now, immunological investigation. Okay, so they said the anti-nuclear antibodies ANA and recurrent pregnancy loss, there is some associations. So if they are positive, that means the prognosis is poor, but no treatment is available for this group. So there is a systemic review, and they explore the association between recurrent pregnancy loss and natural killer cells in both peripheral blood and endometrial sample. So they do endometrial sampling, and in that sample histopathologically they want to see the natural killer cells, and peripheral blood cells also they want to see. But until now the prognostic value or treatment is still unclear, and we will offer these tests only if there is a clinical research. Until then, we will not offer any this test or any treatment related to this test. Okay, so other immunological tests, like for example, HLA, anti-histocompatibility antibodies, and cytokines, they have weak associations, but no evidence-based proven prognostic value or treatment is available. So you will do the test, but you don't have treatment. That what is the benefits of doing these tests? So only the research setting they are doing. Infection investigation, several infections, spontaneous, sporadic, we know that there is a role, but for recurrent pregnancy loss, it's unclear. Okay, so if you will do only investigation if there is a clinical sign and symptoms, and you will not do routine screening for chronic endometritis if there is no evidence base. But if you want to do for research, it's reasonable. You can just take a biopsy sample and just see whether the patient have. We already discussed, we will do some special type of this assay, and we will see this CD, I think 38, we will see that, and chronic endometritis is there or no. It is advisable to offer rubella immunity screening as it is to the patient undergoing infertility investigation. So in the antenatal guideline, we already know now they are no more doing rubella screening, because more than 90% of UK population, they are already immune to rubella because of vaccination. So now they are no more doing rubella screening. But for this one, they are saying, because these patients are infertility clinic, they are coming So there are a list of whenever there you are referring any patient to infertility clinics, there is a list of investigation infection you have to screen, because maybe they need IVF treatment later on. So it should be hepatitis, HIV, and also they are doing rubella screening also. So the male factors, there is a growing body of evidence. There is a association. 2020, the systemic review we already discussed. DNA fragmentation index. It was associated with recurrent pregnancy loss. Okay, and treatment and prognosis still lacking. So summary of investigation. So we have again this table. You can see here RCOG is American board and the Asher guidelines. So generalized RCOG didn't mention anything. They said that medical history relating to recurrent pregnancy loss, you have to treat that medical history, change the lifestyle, smoking, alcohol, exercises accordingly, and general medical obstetric and family history, they just mention about if there is a high risk factor, accordingly you will take general. Genetics, RCOG said genetic analysis on product of conception on third one and subsequent one. Or if you will find unbalanced structure chromosomal abnormality in the product of conception, then you will do parental karyotyping, because it is 2 to 5% only, and it's very low incidence for parental unbalanced or Robertsonian translocation, balanced translocation. So you will only do in routine, you never offer parents directly parental karyotyping. You will always offer first this one chromosomal and product of conception, the third one, and then if it is abnormality, find out unbalanced, then you will do parental karyotyping. And after karyotyping, you also cannot do anything. You just need genetic counseling for the parents that, okay, you have this risk because this baby was abnormal. It have unbalanced translocation because you have balanced translocation. And there is a chance that next pregnancy will be normal. So only for counseling of the patient, you can do this test. In American, what they are saying, parental karyotyping, they are doing, and they are saying karyotyping of product of conception may be useful. So Americans, they are doing directly parental karyotyping. So Ashers, what they are doing, they are not also doing routinely parental karyotyping, and they are using the analysis of pregnancy tissue for explanatory purpose using ACGH. So that's why they are saying, because now they have more advanced technology, and they are doing they are doing investigation after 2 or more. So definitely they are doing, for maybe there is a second pregnancy loss, they are doing this test on the second one, the second loss. So they are using this technique. Hereditary thrombophilias only in women, because hereditary thrombophilias usually related to the second trimester losses. We already discussed that 80% the second trimester causes, they are other causes. 20% only chromosomal abnormalities if it is a second trimester. So if there is a second trimester recurrent pregnancy losses, you think about thrombophilias. Okay. And Americans, they are not doing screening unless there is a research context or there is additional risk factors. Otherwise, they are not doing. Ashers, they are also not doing, or only the same thing. But only RCOG, they are saying if there is a recurrent second trimester losses, 2 or more, you have to do hereditary thrombophilias. And I remember there are some questions related to this one. They are giving you scenario of second trimester, and then you have to select the hereditary thrombophilias testing. Okay. APS, they are again doing antibodies on 2 occasions. Americans, they are doing this the third, this glycoprotein antibodies also, and Ashers, they are also doing this glycoprotein this one in this IgG-M and IgG. Okay, so endocrine, RCOG told unless patient is symptomatic, they are not recommending TSH or hemoglobin A1C. They are not recommending 2011 guideline. But Americans, they said if there is a risk factor, if there is a family history or there is a high risk factor, then you will do, or even screening, they are doing TSH. And Ashers also, they are doing TSH, and they are doing thyroid peroxidase antibodies also. And if abnormal, then they are doing this T4. So this is Asher recommendation. Okay. In this talk article, they mix all these 3 recommendations. But here in the table, that's why at the end of the day, you just need to revise the tables only. Uterine abnormalities, definitely you will do TVS. And then if you need further assessment, if you in the TVS you suspect any abnormality, then you will go for hysteroscopy, 3D ultrasound if abnormal. Americans, they are saying you will do this one, hysterosalpingography, hysteroscopy, and what is this SHG? I cannot see here, SHG. Uh, what is this SHG? I don't. This is saline. I think this is saline, maybe hystros. I don't know what is this one really. Nothing written here. Let me see here. Okay, we'll see later on what is this one. Saline hystroga, maybe Sono, the one in which they are using the saline ultrasound. Okay, and the Asher, they are doing 3-dimensional ultrasound directly. Okay, so definitely who will use 3-dimensional ultrasound? Definitely if they will suspect, then first of all they will do the ultrasound first, and then they will go for the diagnostic test. Male factors, RCOG not doing anything. Americans, they are not recommending this DNA fragmentation index, but Asher is considering for explanatory purpose. Actually, I have read the Asher guideline, recurrent pregnancy loss, and it is maybe a booklet. It's really a booklet. It discuss so many things, so many tests. So they will consider every investigation. They will write consider. So at the end of the day, the conclusion is very difficult. So if RCOG, they make some conclusion, they are not doing this male factors, endocrine they are not doing, or general they are not doing. But Ashes, you will see everything. They will say, okay, parental karyotyping routinely not do, but explanatory basis you can do, or hereditary thrombophilias, if you want to research, you can do, and APS you can do, and this one you can do. Everything they are doing, okay, because they need uh, uh, either the research basis, or they have to give the answers, or if you think you can consider. Immunology, they are not doing RCOG. So they are saying not recommended at all outside a research context. So all the guidelines, they are agreed at least on one thing, that natural killer cell and HLA typing, it's not recommended. So genetic technique available for analyzing product of conception, because karyotyping, what is the problem in karyotyping? Failure of cell culture. There is a rate of 20%. I think it is a very important figure, because in this table they write failure of cell culture is 20%, and maternal cell contamination rate is 22%. So that's why it's limited role. Fish technique, because in practice 24 chromosomes probe, out of 24 chromosome probe, only the 5 to 7 commonly involved in anucleidi are selected. So usually what they are doing, although there are 40 types of chromosomal probes, but only they are using for trisomy, and this one, the 21, and this one, another one, I forget actually, 13 and 18. Yeah, they are using 3 and 2 others maybe. So maybe for Turner syndrome, they are using only for some selected and more common chromosomal abnormalities, although they have 24, but in routinely they are only screening for 5 to 7. So this is the problem. Now this advanced technique, it is called the array based comparative genomic hybridization. So ACGH. Okay, what is the benefit of this technique? Because that's why Asher is using this one, because they have this advanced technique. Why? Because the culture cell failure, there is a limitation. It avoids the limitation of cell culture failure and maternal cell contamination. This is the one benefit. Also, most recommended genetic analysis of product of conception is to be performed. Also, I think it gives the result more faster, because culture will take more time. Although fish will come, the result will come 48 hours, but this one is more better, and the result will come more fast. And then there is a more advanced technique, next generation sequencing, and it is routine. Currently no evidence to replace any other technique. So until this one, you will do ACGH. So this is the proposed testing algorithm for recurrent pregnancy loss based on chromosomal analysis of product of conception. So what you will do first pregnancy, there is a first pregnancy loss and then second pregnancy loss. In second pregnancy loss, according to Escher guideline, you will do chromosomal analysis of product of conception. Okay. If it is euploid, okay, then you will do full recurrent miscarriage workup, because now you will tell there is a more chance also that next pregnancy will end up in miscarriage. If it is unbalanced chromosomal translocation or inversion or this you will do the parental karyotyping, because maybe now they have chance they will have balanced or Robertsonian translocations. If it came aneuploid, you will tell the patient now there is a more chance that your next pregnancy will end up in normal pregnancy, so no further investigation needed. So summary of the current evidence. There is not.
Can you go back, ma'am, the
Uh-huh.
previous slide?
Uh-huh. Anything not clear this one? Okay.
Yeah, okay, ma'am.
Okay. I have to change my glasses. It's very small. Okay, I will see what is written here. Okay, the disorder, now they have giving the summary diabetes. If poor control, yes, it is related to pregnancy loss, and definitely there is a treatment. Yes, hyperprolactinemia, definitely treatment will get benefit, and yes, you will do if the patient have clinical symptoms. Thyroid disorder, hyper, no association, you will not do. But hypothyroidism, there is association with adverse pregnancy outcome, and you will do if there is a clinical. In Asher, they are doing TSH routine, and Americans also doing. But RCOG, they are until now they are not doing as a screening. But definitely it will help, because if you will treat, they will get the benefit. Subclinical hypothyroidism, no association with recurrent pregnancy loss, so recommend investigation, no. Thyroid autoantibodies, they are associated, but the treatment will not reverse the outcome. So recommended investigation, routinely we are not doing thyroid peroxidase antibody screening. We are not doing. We are doing, if we want to do only, we are doing TSH. If TSH come high, very high, accordingly we will do T4. If need thyroxine, we will give treatment for hypothyroidism. If TSH normal, then our aim is to keep the TSH level up till 4 milli international unit per liter. Okay, if it is 4, then no need to give treatment. If it is 5 or more than 5 TSH and T4 is normal, then in this case you will give treatment for subclinical hypothyroidism. So aim is to keep 4. Androgen disorder, no, no association with recurrent pregnancy loss, like they are talking about PCO. And I'm surprised, because last RCOG guideline, there is they said very high percentage for recurrent pregnancy loss, but now with PCO they are saying there is recommended investigation, no. So they are not doing now, no more FSH LH for diagnosis of PCO, or there is no association. Diminished ovarian reserve, they said it is associated but no prognostic value. You cannot say, you cannot, on the base of this diminished ovarian reserve, you cannot take any decision, and recommended investigation, no. Hyper homocystinemia, no association, no. Luteal insufficiency because of lack of definitions, lack of diagnostic test available. So they are saying no. Luteinizing hormone, no. PCO, no association, no. And vitamin D deficiency, no association. So all are no. So definitely it's more easy if there are few yeses, we just focus on the yeses. There is a yes for hypothyroidism, because you will give treatment and recommend investigation, yes. Hyperprolactinemia, yes. And diabetes, yes. And all others, it's no. And again, chromosomal abnormality, yes, you will take pregnancy tissue. Definitely, accordingly, you will do parental karyotyping if pregnancy tissue become this one. If aneuploidy, definitely you will not do anything. If it came out to be unbalanced translocation, then you will offer parental karyotyping. If it become euploid, So you will not do parental karyotyping, you will just do all the other investigation of recurrent miscarriage. Anatomical abnormality, the first line is 2D transvaginal ultrasound, and accordingly you will offer them hysterosalpingography or 3D ultrasound, and accordingly then you will advise them hysteroscopy, laparoscopy, or MRI according to situation. So individually assessed MRI, laparoscopy, hysteroscopy individually. Otherwise, routinely 2D TVS or 3D pelvic ultrasound, because Asher they directly advise 3D pelvic ultrasound. Okay, so thrombophilias, I think if you will do 2D TVS, it's equivalent to 3D abdominal ultrasound, because the information giving you the TVS ultrasound is maybe the same like you are doing the three-dimensional pelvic ultrasound. Thrombophilias, acquired thrombophilias, recommended. Acquired thrombophilias, you will do recommended, and hereditary thrombophilia only if there is a personal or family history of thrombosis. uh, Then individual basis. Asymptomatic, if there is only history or there is a history of carrier status, or if there is a poor pregnancy out before, maybe she has venous thromboembolism the last pregnancy, that's at the part of investigation of, because you want to give treatment, maybe you want to do. Otherwise, routinely you are not offering. Endocrinological TSH and this hemoglobin A1C you will do recommended, and individually according to TSH level you will do T4, and according to patient, if patient have amenorrhea or irregular cycle, then you will do prolactin. Otherwise, if patient have regular cycle, you are not doing hormonal FSH, LH, and prolactin. So in the exam you must focus according to symptoms, because every investigation is individualized, there is nothing generalized. This according to situation, what information they are giving you, accordingly in the EMQ option you will select that information, that investigation. No evidence to do this one. Thyroid antibodies you are not doing, testosterone you are not doing, and sex hormone binding globulins you are not doing, routinely you are not doing. So definitely the PCO, if if the patient is asymptomatic, then you will not search for PCO. Maybe she's a diagnosed case of PCO before, but if patient will come to you with a recurrent miscarriages, and that means she's getting pregnant, right? If she's getting pregnant after having PCO, then you will not do these investigation. Immunological, it's not recommended, but and this anti-nuclear antibodies is recommended by, I think, Asia guideline. They are recommending this one, and it is associated with poor prognosis, but no evidence to do natural killer cells and HLA and this IHA cytokines, research only. Infections, rubella immunity screening now you are doing, and maybe this is exam question, because in the antenatal latest guidelines they are saying no more rubella immunity, but maybe they will ask you, and don't confuse yourself. In the infertility patient we are doing rubella immunity screening, but for the normal low risk antenatal population, no more rubella immunity screening. Okay, so individually you will do high vaginal swab, chlamydia, endometrial biopsy. They said chronic endometritis, you want to see that CD, this one, this histo compatibility, this one, I really forget this essay you will want to do. Maybe you want to do on the research context, or maybe some time for patient counseling, you can individually assess, you can do. And no need to do a torch infection screening. Male factors, RCOG is not recommending, but individually assess if sperm DNA, maybe if father age, they give 45, for example. Maybe in that scenario, you want to select sperm DNA fragmentation index, maybe. Or maybe they will give you some abnormalities of the this one, this semen analysis, or in that scenario maybe you want to select this one, because it is individually assessed, and the Americans and Asher both are saying that you can offer them. So treatments, while evidence-based treatments are limited for recurrent pregnancy loss, patients prefer to have a plan for the next pregnancy. Okay, such plans are usually dependent on if any modifiable causes. Definitely, if the patient come to you in the recurrent pregnancy loss, and she want before getting pregnant, she want to have a plan, and you give the plan only for those. For example, if she's diabetic, you will give the plan for treatable causes that control your diabetes, control your general lifestyle, control your thyroid. You will just, these plans are given if there is any risk factor which can be modified. For example, you cannot modify the age. If the woman is 40 years, you will counsel her that this risk factor is not modifiable. So like that, need counseling and before giving any treatment. So chromosomal abnormalities, what you will do, already we tell, if the parents will come, they will say that you have balanced translocation, you have Robertsonian translocation. So what I will do now, I have this diagnosis, will take for genetic counseling. Okay, so although the option of pre-implantation genetic testing has been shown to reduce the number of pregnancy losses, but no overall difference in live birth rate. So now the major trial, which is called the STAR trial, and it published in 2019, it shows no improvement in pregnancy outcome from the use of IVF in combination with pre-implantation genetic diagnosis for aneuploiding screening. So full stop. Now they have this trial, and they have, it is multinational, multi-centric randomized control trial. So it's a big trial. So they said no need to do routinely because you have recurrent miscarriages. Now you are with IVF. You just want to do IVF because getting pregnant it's not a problem, but just you just want to do IVF because you want to do with IVF pre-implantation genetic diagnosis. For this purpose, they are not, the pregnancy outcome is no more improving. So you will not offer this one. So anatomical abnormalities, most common was, we know, the uterine septa. And they said if you will treat the acquired causes of uterine abnormality, for example, the fibroid, submucosal fibroid that distort the uterine cavity, it will improve the live birth rate. But the direct association or that treatment improve the outcome for acquired, such as polyps or uterine adhesions, there is a lack of evidence. Uterine adhesions like Asherman syndrome, that you treat it and maybe there is improved outcome, we don't know. Or polyp, if you will treat the polyp, it will improve the outcome, we don't know. There is a lack of evidence. But for submucosal fibroid, which is distorting the uterine cavity, they said it improving the live birth rate. And also they are saying the hysteroscopic septal division reduces pregnancy loss rate and resulting in live birth. So it's because the high quality evidence of the efficacy and safety of the surgical treatment you can offer only individualized basis, because you cannot do a randomized control trial on this type of patient, that you will treat one patient and you will not treat another patient. So it's very difficult to do a randomized control trial for these type of patient, these type of situation ethically. So in these cases you will just do individualized treatment by the experienced specialist. So acquired thrombophilias, heparin or low molecular weight heparin, unfractionated heparin combined with low dose aspirin, it improved the live birth rate and the birth weight also in the recurrent pregnancy loss. And it has a benefit low molecular weight that you have to give once daily, and it have a good safety profile for thrombocytopenia and osteopenia over ultrafractionated heparin. So we all know the risk of thrombocytopenia and the risk of bone loss is more with ultra-fractionated heparin. Recommended treatment for APS patient is start aspirin and prophylactic dose from a first positive pregnancy test. So before they said wait, start aspirin, and when cardiac activity comes, start prophylactic. Now they are saying no, just when the pregnancy test is positive, start both together. However, these patients should be recommended to discuss plan of pregnancy in advance, because if they are already diagnosed, definitely they have been diagnosed before pregnancy. So before pregnancy, anytime a pregnancy test positive, they have to already they know what they need to do. Okay, so immunological treatments, systemic review, no improvement in the live birth rate. When you are think about giving immunotherapy, only clinical research context you can use. Endocrinological treatment, if there is uncontrolled diabetes, thyroid, hyperprolactinemia, you can give them preconception advice, and you can give input from specialist care. Your target TSH is less than 4. And you will not give any treatment if the patient have thyroid peroxidase antibodies, but she has normal TSH. You will not give any antibodies. Sorry, you will not give any treatment. Sorry. And metformin for PCO patient, it will not improve the pregnancy loss. Or so metformin for the PCO patients so that they will not have recurrent miscarriage, it's not proved. So male factor treatment, no specific evidence base is available, but only you can tell lifestyle modification, smoking, obesity, excessive exercise to improve the sperm DNA damages. Okay, 2019 Cochrane review, they looked at the antioxidant used for males of fertility. There is a low quality evidence, but they said that if they will use the antioxidant supplements, it might improve the live birth rate. So individualization should be considered. So unexplained pregnancy loss treatment, there are two major trials. We remember in the RCOG, they mention about the PROMISE trial ongoing. We are waiting for the result of the PROMISE trial on unexplained recurrent pregnancy loss, the role of progesterone. Now the result of this PROMISE trial has come already. So it was for several years, unexplained pregnancy loss, progesterone has been given. So 2019 Cochrane review, they said it may reduce the rate of pregnancy loss in further pregnancies, so you can give. Also there is a figure, I didn't mention that forest plot graph. They show the live birth rate or continuous pregnancy outcome with progesterone versus placebo or no treatment. They increase significantly. Yani if you will give there is a 70% with progesterone, it increases 75% live birth rate. Yani if you will give no treatment or placebo, it is 71% live birth rate, but if you will give the progesterone, it is 75%. So this paper, basically, they extract this forest plot from two trials. One was the PROMISE trial, which is a very famous trial, use of vaginal micronized progesterone on live birth rate in recurrent pregnancy loss. And the another one was threatened pregnancy loss, which is the PRISM trial. It was in the recurrent pregnancy loss and it was in the PRISM trial, and they showed that small but positive treatment effect depends. So authors believe that the dual risk factor of early pregnancy, bleeding, and a history of one or more. If, for example, a patient have bleeding, she has threatened miscarriage, and she has history of one or more previous pregnancy loss, so she's a high risk and she can benefit progesterone. So you can communicate to the patient that okay, you need treatment. First of all, we identify, then we treat, and there is a different dosages. So maybe the dosages may become in the exam because it's a little bit different. They said if the patient have bleeding and history of one or more uh, previous pregnancy loss, so you will give 400 milligram twice daily. So when the patient presents vaginal bleeding, and you will continue with 16 weeks completed weeks of gestation. I think we have read it this one that until 16 weeks we completed this one. This completed weeks of gestation. Threatened miscarriage in the NICE guideline, it's written there that 16 weeks, until 16 weeks, you will give the progesterone. Then if the patient have recurrent pregnancy losses, okay, but no bleeding, currently she has no bleeding, you will give her 200 milligram twice daily. But if she will present with the vaginal bleeding, you will start at the time of vaginal bleeding and continue until 12 completed weeks of gestation. Okay, and you will increase the dose and continue until 16 completed weeks of gestation. So I don't understand this. What is the difference between this one? They said it is recurrent. You start as an asymptomatic patient, and if patient comes with you with the bleeding, you will continue until 12 weeks of gestation. But if any vaginal bleeding, then increase it to 400 milligram daily and continue. My understanding is that if asymptomatic recurrent pregnancy loss, you give 200 milligram. If patient have threatened miscarriage and recurrent pregnancy loss, you again give her 400 milligram twice daily and 16 weeks. Or if patient have vaginal bleeding and she has one miscarriage before also, you have to give 400 milligram. Any patient with high risk, previous one history or previous three history, with threatened miscarriage, you give 400 milligram twice daily. If patient is asymptomatic and she has recurrent pregnancy loss, you give her 200 milligram twice daily. So general treatments, you will offer general treatments, Cochrane review, that you will give progesterone supplements, and also I think I discussed this one. Yeah. So general treatment is lifestyle, okay? And if the patient BMI is greater than 30, then high dose folic acid should be recommended. I think Dr. Iram, she will tell you best in pregnancy. This thing she will discuss there. Also, vitamin D supplementation preconceptionally or during pregnancy. Also, potential treatment will be individualized psychological support, lifestyle, planning future pregnancy, early ultrasound, appropriate contact numbers, and also despite a diagnosis, 70% of patient will achieve a live birth in their next pregnancy. So this is two-third, almost two-third of the patient, they will have a live pregnancy, even if they have recurrent pregnancy loss. So this is the summary. Already we discussed I think this is the first. We discussed this one. What is the treatment? This is a summary of treatment options. Summary of treatment options from different guidelines. So I think it must be written here RCOG. It's written American. It's written here Asher guideline. So here balance chromosomal abnormality. If the parents have balanced chromosomal abnormality, what you will do? You will give them genetic counseling. And in the RCOG old guideline 2011, it was written that IVF and pre-genetic diets you can give optional, optional. Although in the Cochrane review they said this no benefit, but I don't know why still they are writing here optional or optional. But the systemic review and the meta-analysis already showed that it does not offer any benefit, does not improve the live birth rate. But anyhow, optional is optional. APS, you will give low dose aspirin or heparin, okay, low dose aspirin or ultra fractionated heparin. This Americans, they do everything differently. And then Asher's low dose aspirin starting preconception, low dose aspirin, they are starting before pregnancy. So there is a difference. In the Asher, they started before pregnancy aspirin. And then prophylactic either this one from first positive pregnancy test. So Asher is writing from first pregnancy test, but in the RCOG guideline, I remember they write start aspirin from the start of the pregnancy and heparin if pregnancy test positive. But definitely in the new guideline, the draft guideline, I'm 100% sure they will also go with the first pregnancy test positive, start both together. This one, but this aspirin in the Asher, they said before conception, and we don't know what will be done in the RCOG guideline. So thrombophilia's insufficient evidence, we cannot do anything unless patient is asymptomatic. Americans, insufficient evidence, no recommendation unless there is a context of research. In the context of research, Asher do every investigation, individualization. They said individualization and do. Endocrinology, insufficient evidence. You will not give asymptomatic if patient don't have symptoms, insufficient evidence. And Americans say you will definitely treat the maternal disorders, endocrine, thyroid, diabetes, hyperprolactinemia. Other treatments not advised. And here also Asher's hypothyroidism, levothyroxine, hyperprolactinemia. They are all saying the same thing. Uterine abnormality, insufficient evidence. Americans say consider surgical correction. Also, Asher saying insufficient evidence, but in septum correction in the context of trial. Again, they are saying that if there is a trial, you can get because we cannot do randomized control trial for this treatment modality. Unexplained supportive care in the dedicated early pregnancy assessment unit EPAU. In the exam, sometimes they are writing EPAU, which is the early pregnancy assessment unit. In the NICE guideline, we heard lots of this terminology. So this EPAU is the supportive care only. They are not giving any treatment. TLC, total loving care, counseling support, also Asher supportive care, no therapeutic intervention. Okay, others, no immunological treatments, no progesterone. So unexplained, I don't know why they are not writing here unexplained progesterone. Okay, so summary of recommended treatment options for recurrent pregnancy loss. If chromosomal abnormalities, you give pre-genetic, this one, what is this PGT? Pre-implantation genetic testing for structural rearrangements. Okay. And then individually you will do pre-implantation genetic testing. It's for aneuploidy. Okay, PGT, maybe they are using terminology in the UK, and PGT-A is for Americans. Anatomical abnormality, surgical treatments of fibroids, okay, or they are also, Americans also saying surgical treatment of uterine septum polyps or adhesions, and Asher's also saying surgical treatment. Thrombophilias, either heparin and aspirin for APS, or they are Asher's, they are treatment for congenital thrombophilias. They are offering, but definitely there must be some reason. Not asymptomatic patient they are not offering, but maybe symptomatic patient for congenital thrombophilia you will give. Infections, antibiotic if evidence of infection, and prophylactic antibiotic. They are offering prophylactic antibiotics. Maybe history, if there is a previous history, then you might want to give prophylactic antibiotics. Immunological, RCOG nothing, Americans nothing. Asher's, I told you in the Asher guideline, you will be very confused because even they discuss this prednisolone. They said some of the clinical research, or there's a good practice point. Some of the private doctors, they're using prednisolone, so maybe they have success, but the evidence is not so uh, convincing or like that. But they definitely they pointed toward this use of prednisolone, immunoglobulins, intralipids, and partner lymphocyte transfusion. They have mentioned all of these modalities. Endocrinology definitely is the same things, and the same thing that if treatment for subclinical hypothyroidism or thyroid peroxidase antibodies, androgens, and this one HCG. Okay, so male factors, lifestyle modification. Americans, they're giving them antioxidant supplements. Or unexplained, yeah, here written unexplained. So why not written here? I don't understand this one. Unexplained, here they just write supportive care, but here a summary of recommended treatment. Okay, so actually now I understand. Here in this table, actually in this table, they said summary of treatment options from different guidelines. Yani the guidelines are saying like that. For unexplained, supportive care, supportive care, supportive care, no therapeutic intervention. But if you will see summary of recommendation, what is summarizing? The summary is after they are collecting all the data as a generalized after from the trials. That's why in unexplained, because it is a trial, promised trial. After that trial generalized recommended treatment, they said unexplained you will give progesterone. Now no more tender loving care only. In addition, because after the trials result came, this progesterone you can give, because maybe Asher came in 2017 and the result of trial maybe came later on, so that's why she make another table, and she make after the trials what exactly. Now this is the end point actually. So in the end point unexplained you give progesterone. For male factors you give lifestyle and individually assess antioxidants. For endocrinology, definitely you will treat all the endocrinological abnormals, but for subclinical and for thyroid antibodies, you will not do any treatment. Just aim is to keep four. Androgens and SCG you will not give. These are not recommended treatments. And you will not do androgens, FSH, LH, and testosterone for diagnosis if patient is not presented to you with this one. Immunological, you will not give prednisolone. Sorry, I didn't see here. It was written no evidence to give. So no evidence to give. They mention it in the Asher guideline, but there is no evidence. Prednisolone, immunoglobulins, intralipids. There's no evidence here. You are not giving. Prophylactic antibiotics, no evidence to give. Okay, unless you are doing in research basis, unless you are suspecting something. Otherwise, prophylactic antibiotics for chronic endometritis, if you are not suspecting, you are not giving. Or maybe for a reason you do biopsy and you find chronic endometritis, maybe. Otherwise, no evidence to do. And there is big trial is going on. And then no evidence to do treatment for congenital thrombophilias. That's what we are talking about. We are not giving asymptomatic thrombophilias. We are not giving treatment. No evidence to do surgical treatment to other Mullerian abnormalities, only uterine septa. They said you can do polypectomy, you can do adhesiolysis, you can do individually assess, because the chance of live birth is the lack of evidence. But definitely recommended is surgical treatment of fibroids, which is distorting the uterine cavity. So recommended is PGT for such structural arrangement and PGTA individually assessed, but no, okay. So no evidence to do immunological. It's not recommended, no, individually not recommended. And this one, okay, this is clear also. So male factors individually assessed, unexplained, write this. Generally maintain normal BMI, stop smoking, vitamin D, tender loving care, and dedicate recurrent pregnancy loss clinic. This is generalized. Individually limit the caffeine less than 3 cups a day. So this is the summary. Until now they discussed, this is the summary. So it is more easy. Sorry to make confusion, because I thought I divide the table in half. That's why I was thinking the same heading. So this is from RCOG, this is from Americans, and this is for this one, Asher guideline. Okay. Okay. Can you tell me, can you open, because I share in the group this Microsoft Sway. Can you open yesterday my slides or no? Anybody open my slides yesterday? Yesterday guidelines?
Yes, madam, we can open.
You can open. Okay, then I will share in the group. You can see this is the summary, because when you read a talk article, sometimes become very boring. It took me full day to prepare this presentation, so it is very any tiring. Okay.
Yes, madam, please.
Okay,
Yes,
fine.
ma'am, it is like that. Like even with consent advice, it took me a day to understand
Hmm.
how to, you know.
But actually in this process I learned more than you, really, this is the fact. Because when you are teaching you are learning more, but when you are listening, the you will see this one, the retain of memory after taking the lecture is only 5%. You will forget 95%. So you need to either after this lecture, either you go back to your question answer, this one practice, do question answers, or go back to your guideline, learn yourself and discuss with your friends also. Any, this is just to give you the idea, because recurrent pregnancy loss, I have some questions if I will ask you, because these are old questions, so I will just ask you if it might be some benefit what they are asking actually. Okay, they're asking because I have old questions in which old percentages. So uh, they have one question. A 35 years old woman with a history of 3 recurrent miscarriages presented to you for advice regarding the risk of miscarriage if she conceived. So pick the best option to describe her risk from the list below. So this is common question they're asking if 35 years old. Now, first of all, you have to
25%.
how much?
And 25%.
No, actually, I was just trying to say you that 35 years old, this is one thing you have to focus, because there is a baseline risk of age-related miscarriage risk, 35%. Okay, I will open that slide also. Wait. This is more easy way. Wait. In the start, that table was there, no? Epidemiology, I think in the epidemiology, yes, that table is here. Yes. So age-related risk 25%. So this is the sporadic miscarriage risk, right? It's not recurrent miscarriage risk. So this confusion. After that, now she's 35 and now she has 3 recurrent miscarriages. So now what is the risk? I will tell you the answer because it's confusing. Because the key is the risk of miscarriage who have not been investigated and no cause has been found. you need to be careful about whether or not you are dealing with unexplained recurrent miscarriage or there is a cause of miscarriage, because the guidelines say the risk of further miscarriage increases with each successive pregnancy loss, reaching approximately 40% after 3 consecutive pregnancy loss, and the prognosis worsen with increasing maternal age. So they say that we don't know what they are asking. Either they are asking about unexplained risk miscarriage rate, or they are asking for this one the other miscarriage, other recurrent miscarriage rates. There might be some cause. So after this, they said it is 40% total, because 25% is the baseline, but because of recurrent miscarriage rates, the baseline is increased and it become 40%, and the same wording is written in the RCOG guideline. So we will wait until the new guideline will come and what they will say. Okay, whenever they're asking the recurrent miscarriage rate, just focus on the, don't forget the age also, maybe 40 years. The same risk they are asking you, that patient is 44 years and now she came to you, and what is her recurrent, and she has 3 current miscarriage. Now what is her risk? Definitely the baseline is 51%. In addition to baseline, now she has recurrent miscarriage rate. It must be very high. It must be maybe around 70%, something like that. So these are some confusing questions. Okay, one more question. A woman present to the antenatal clinic for booking at 6 weeks. She has history of 3 recurrent miscarriage with no explanation found after full investigation. Now, what is her risk of miscarriage in this pregnancy? They didn't mention the age in this question, but they just told without any age. Just she's a woman and maybe she's 29 years. The baseline is 12%, for example. Now she has 3 unexplained miscarriages. So what is the risk of miscarriage? In the guideline, they said because they give the figure of successful pregnancy 75%, right? They give you the risk, the chances of having the next pregnancy successfully is 75%. So definitely in this case, the risk will be 25%. I know it's very confusing, but anyhow, this is the way they are asking question. Okay, so just wait for, because I'm not focusing, but I'm just trying to tell you, whenever there is a percentage related question, these things are must be in my mind, that focus. Either they're asking about the unexplained recurrent miscarriage rate, or if you know what is the success pregnancy rate, that they have the chance that 2/3 will have the normal pregnancy, or 70% will have this live pregnancy birth rate. So that's mean indirectly the next pregnancy 25% miscarriage rate. So maybe they want either way. They will not ask you one percentage, they will ask you the other percentage. They will ask you the miscarriage rate. In the guideline, they give you the success pregnancy rate next pregnancy, but maybe they will ask you the risk of miscarriage, right? So just focus when the new guideline will come.
But madam, in the old guideline, they mentioned that only sportive management in recurrent miscarriage, the success rate of the next pregnancy was 90%.
For which one? Unexplained or the one
Recurrent miscarriages.
90% they said?
I think so. I read a very long time ago, but 90 success rate 90%.
No, it's written
I
the
will read
no,
again.
no,
I
no.
will
In
read
front of
again.
me, there is a guideline. The guideline says women with unexplained. Okay, they have the excellent portion, but 75% with that tender loving care. Okay, I don't think so. They just mentioned 75% here. Okay, and it's not about unexplained. It's about just
Recurrent.
recurrent. Yes, it's 75%.
Okay.
So for this patient, the risk of miscarriage will be 25%, because they're asking the risk of miscarriage. They didn't give the any age. So just I am just because after 3 miscarriage, still the pregnancy success rate is 75%. So if they will ask you what is the risk of miscarriage in this person, so in the other side there will be 25% chance. In the patient counseling, you will tell her either you have 75% chance of live birth rate, but still there is a 25% chance that you will miscarry again. That's why we are offering her investigation, right?
So if no age given, then the success
No,
rate
no, no, they will
75.
give you a, don't confuse. This is the questions I am reading from Dr. Tom actually. So he is
Okay,
always
okay,
giving this type of questions.
okay.
Okay, I don't have this other source because if you will see his questions, I never listen to him because very confusing. I actually start my preparation from Dr. Tom. Okay, I think any question, 1.5 hour already finished. Any questions related to this presentation? Anything? Either you fully understand or either you confuse yourself. So better to go back to your guideline and sorry article and go back and see the article, okay, because it's not easy article. Anything? Okay,
Uh,
so first of all
Thank you,
let
ma'am.
yeah stop share one by one and then I will stop recording. Please, whenever you after this class, don't select the link, because when you select the link you will, I don't know how you press the recordings for yourself. Don't press the recordings. I will stop recording or I will pause the recording. I will stop